Coming up next, it's your Pulse Radio Show. Brought to you with the compliments of MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
A pleasant good morning. Yes, we are here again with you on the Pulse Radio Show, the Queen Elizabeth Hospital's production that allows you to get all of the information you need about our hospital. I'm Shane Seeley, Communications Specialist at the Queen Elizabeth Hospital, and we're going to spend the next roughly 55 minutes telling you about some of the new initiatives to help improve our services across the board. And it's a big one today. It's something that is kind of new for us, and it will really speak to how we can improve the efficiency and deliver that kind of service that you demand of us. Remember, you can call us here on the Pulse Radio Show at 434-1007 or 434-1070. You can send us a WhatsApp as well at 434-1007. So remember, we want to hear from you. Any concerns, any questions, any compliments, any proposals that you want to share with us to help us, deliver that better service that you demand. We are here to listen and to help, and also to guide you as well. Remember, we always guide you through the patient advice and liaison service, or help desk, or your hospital pal, at 536-4800. And then we also have that other service that we want those of you who come to our pharmacy to connect to make it a whole lot easier for you to get your medication delivered right to your door or even at work, the medication delivery service. And for that service, you can call 536-4804 and you can get information, or you can go to our website, www.qehconnect.com. That's www.qehconnect.com. And you know what? You can use that for all the information that you need with the medication delivery service and other things that you may need from our hospital. It also allows you to listen to this program. We have the podcast from the other 3 seasons plus this one, so you know that if you need to go back to get any information, you do just that on our website as well. So we were on Morning Barbados, and I say we because I have 2 special guests here with me again. They've spent basically the entire morning with me, sharing with you what is a new initiative at our hospital. So let me welcome back again my co-host, and also I say co-host because when I go on vacation, she will be the one making sure you get the information. Dr. Ayja Clarke, Service Improvement Manager. Good morning again. Welcome back.
Good morning. I'm so happy to be here this morning.
Of course you are. Of course. We can't do this sharing of this special project without you. And we can't do it without Tricia Ward, who is our quality lead, acting quality manager at the hospital. Morning to you, Tricia.
Good morning to you and everyone out listening.
Yes, so your first appearance here on the Pulse Radio Show, but you did a stint with us this morning on Morning Barbados to talk about the estimated date of discharge and what that all means for our patients and for their families. So let's start with where it all came about in the committee. And I mean, you could tell us a bit about the committee and the work, and then we will get into Dr. Clarke's side with the board, which dictates how this process is supposed to work. So yes, give me from the concept, how did it come about, Tricia?
Okay, We were having some issues at the hospital as it relates to discharge for our patients and also our bed management. So we have a discharge planning committee that would have sat and they met, and we would have launched a policy, discharge planning policy, which looked at from the patient's discharge that they're supposed to have the estimated date of discharge on admission. So we looked at that, and
you created a video to explain exactly how that would work.
Yes. So we would have created a video, and then we decided also that we needed to have the estimated date of discharge on the patient's bedside. So when the patient is admitted, the patient knows how long they'll be in hospital and when they'll be discharged, and they can manage that with their families and their relatives. And the hospital itself will come together with all the different things like the labs and the other entities as it relates to the patient care to meet this estimated date of discharge. And then the pilot came about from there. In order to sensitize our staff and our public, we thought it was best to communicate via a video. So we launched a discharge planning video, which we would have aired this morning. And plan that video, it shows you how much the hospital is working with you to ensure your safe discharges. And the estimated date of discharge does not impact on the clinical service that we give to you. Because we would have launched an estimated date of discharge, it's based on the clinical science as it relates to your medical illness as you are coming in, and it will not impact on you. And Dr. Clarke will continue to explain that to you when she speaks about that part of it. So in the video, you will see a group of persons coming together, a clinical team coming together to work with you at your bedside. In the video, we would have had the patient that came in was a stroke patient. And every Thursday in our stroke unit, we usually have a team. You have the physiotherapist, we have the dietitian, and the speech therapist, and various other persons coming together to work with those patients. That particular feature that you will see is not necessary for all patients, so it will not be seen at every bedside. But where there's a need for another service to come on to help to manage a patient care, that is done. So we just want to make that clear to you, because it does happen every Thursday on the stroke unit, but it's not necessary for all patients in every area.
And we will make that video available shortly on our website and on our YouTube channel, so you can connect and see exactly what that patient flow and estimated date of discharge dictates, what the whole process looks like. It's all part of service improvement, and it falls as well under our service improvement manager, Dr. Ayja Clarke, back with us. Long morning, good to have you here on the show, Dr. Clarke. Talk to us about the boards, and I know that you will describe the boards and give that title to them and go through all of that, but talk to us about the pilot project which you were spearheading on our wards to make sure that this process became a bit more seamless than it started out, I should say.
So we can take a step back and talk about what the estimated date of discharge actually is. It's just that, an estimate. So the doctors, when they see you for the first time and they're admitting you to the hospital, based on your diagnosis, so what condition you come into the hospital with, they're going to determine when they think you're likely to be able to go home. It's an estimate, so it's not, set in stone. So you might get better a bit more quickly and go home sooner, or you might take a little longer to get better and go home a little after your estimated date of discharge. And as Tricia said, this is not to replace, the experience of our doctors who have worked in the hospital with these conditions for a very long time. And it's never supposed to replace the safety of the patient. So for instance, if your estimated date of discharge comes and you're not ready to go home, we will not send you home. The aim is to do it safely. Now, what we did, the aim was to have this estimated date of discharge easily accessible to everybody involved in the care team. So that includes the doctors, the therapists, the support services that the patient gets while in the hospital, the nurses, and very importantly, the patients and the relatives. So we decided to put it at the bedside. As Shane said, we first started out with a pilot. We know when we're doing any project, sometimes it can be difficult to go full steam ahead. You want to try it out first and, essentially work out the kinks. So we did 2 pilot projects. The first pilot project was just 5 boards, 5 estimated date of discharge boards on 5 wards in the hospital. We got feedback from all of the staff involved in that process and from the patients and the relatives. So we asked them what they thought about it, what could be done better, what could come off, what could stay on, what could be added. And based on that, we made changes to the board to come up with the second version of the board. We then did another pilot on just 2 wards. On these 2 wards, we did a full complement of boards, so 24 bedside boards were on these wards. And the aim was to see how much work would this be for the staff to really maintain. And we collected feedback, again, from the staff, patients, and the relatives involved in the pilot to see what they thought about it. And we've come up with the final version of the boards that would be available to be seen on most of the wards in the hospital come the week of November the 1st. The estimated date of discharge board, as the name suggests, is actually a board and it's attached to the patient's bedside. It has on all of the information that's important to getting that patient home and out of the hospital safely. And a delay in any one of those things, we know, can lead to a delay in that person leaving the hospital and leaving that bed. When we talk about patient flow, everything that happens in the hospital and the patient's journey is interconnected. So in order for persons to be admitted from the accident and emergency department, persons have to leave the ward upstairs and be discharged home safely. All right? And when we have delays in discharge, we have delays in admissions. And we see how that process can follow along. So the estimated date of discharge is to give everybody in the care team a central date to be working towards. So for the patients, for instance, a really important thing for them is that it allows them to be part of their care process. So they know that I might go home by this date. I might expect that I might have blood taken from me on this date. I can expect that I might have this test done on this date. We know that when you're in a hospital, it can be associated with a lot of anxiety, a lot of uncertainty, and the board is supposed to help to alleviate that.
Okay, so we have that board. What feedback have you received during the pilot? Let's start with staff.
So initially, with any change process, it has been a bit of an uphill battle, but I think they're coming around. I think that they're starting to see the value in the board when it's used properly and appropriately. But when we talk about the patients and the relatives, there's been a resounding, from all of the patients and relatives that I've spoken to, that they definitely think the board is valuable. They're very excited to be able to see, their relatives' information, and the patients are excited to know everybody wants to go home when they're admitted to the hospital. So they're very excited to see, when they might be able to go home and what's happening in the process. When we talk about the staff as well, they have been, obviously it's a different task, so it's a change from what they're used to do, to be doing. But I think that, as Shane mentioned this morning, the only thing that's constant is change.
Yeah, it is. That is very true. And we must change so that we can develop better processes so that our patients feel more comfortable during their stay at hospital. You said it correctly just now. Anxiety is one of the things, primary feelings, because you come into the hospital, you're unwell. When you come to us at the Queen Elizabeth Hospital, you're normally at your lowest. You're trying to find out what it is that has me feeling the way I do. You want some corrective action, and it most of the time is urgent. That's why you start in the accident and emergency department. And you go through that process, and when on admission through the accident and emergency department, you get that diagnosis, and these things go on the discharge board. You are in a better position to understand. Your family's in a better position to understand what they do and prepare themselves in that regard. Tricia, how has it been for you in terms of getting the information across to staff, read the EDD boards, the estimated date of discharge boards?
Well, initially, as Dr. Clarke would have said, persons had various concerns when it relates to the EDD boards. Staff thought it was a breach of confidentiality to the patients. Presently, most of our wards are open wards, so they felt that the neighboring patient might give information that is on the board to someone else in the community and talk about what is happening with the patient. But we were able to resolve some of those issues when we looked at the international standards as it relates to these boards on the bedsides on open wards in various hospitals in other regions and islands. And we decided then that we would look to put what was pertinent to the patient's care without disclosing any information about the patient themselves. And that is why on our boards we will have more dates. And the reason for this, we also want the family to be also engaged in these boards. We want the patient and the family, because we have recognized that when patients and family are engaged in their care, that there's more compliance with the care of the patient. They can make better decisions when it comes to their care. And that is something that we want going on throughout the hospital. We want families and patients to be a part of their care. We don't want it in a situation where doctors are just talking to the patient, but the patient can make concise information when it comes to their care. So we want them to be a part of these boards. We want them to be able to look at the board and recognize Dr. was supposed to have a lab done. I'm not seeing anyone coming to take me for their lab, and hold us responsible
And
to these dates,
yes.
and accountable to these dates that we have on our boards.
Indeed. We'll take a quick break. We're talking about the estimated date of discharge boards. They're coming to the hospital. They're at the hospital, but we are going to roll them out officially very soon. Dr. Clarke will talk a bit more about that, and Tricia will give you more details when we return from this break. Of course, the QEH Pulse radio show brought to you compliments MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Back with you on the Pulse radio show. Shane Seeley, communication specialist, here with you along with Dr. Ayja Clarke. She is our service improvement manager, one of 3. And we also have Tricia Ward. She is our acting quality manager, helping you to better understand what is happening as we launch our estimated date of discharge boards, which will help streamline patients and their pathway going through our hospital. So that's where we were, talking about these boards and looking at the feedback. So far, so good. So what happens next? You've done your pilots. What next?
So the pilots, the main thing we wanted to look at in the pilots was the feedback from the staff. We wanted to create a product that was usable, that can work, and that can seamlessly integrate into what the staff already does so well and make the process even better. So we use that feedback to change the board up and really to take their recommendations into consideration. And that has really guided the final product that we now have that the public can see on the wards. The next step is procuring the boards, sensitizing all of the staff to the process, getting everybody on board and educating the staff, sensitizing the public, which is what we're doing here today, and rolling them out. As I noted, we had some pilot wards. So we had wards where, we tested out the boards, but some of the other wards in the hospital obviously will not be sensitized to them. So our aim now is to get everybody on the same page and teach everybody, what's the best way to use the boards and how they can help them. So that's really our next step.
Next step, indeed. Tricia, you were responsible for creating the video, and I guess you would get a sense of how the reaction could or would be through those who were participating in it. Was there any apprehension, or it was just all green light? We're happy with what we're seeing. We're happy to participate.
The aspect of the video, everyone liked the video. They liked the teaching and the engagement that the video would have brought. So I didn't get a lot of negative feedback as it relates to the actual video. The feedback was pretty good with the video. People were clear, they understood where we were going, and the feedback was pretty good as it relates to the video.
And during the meetings of the committee, what were some of the standout things that suggested, look, that this could be a hit not only with staff but patients?
The standout thing that they queried as it relates to the video was as it relates to the multidisciplinary team around the bedside of the patient. And they were a bit wanting to be clear that we don't give the wrong impression as it relates to that. But we were able to clear that out when we allow them to know that that is something that happens at the QEH, but it's specific to stroke patients. And that's something that happens every Thursday with stroke patients.
So it would vary. The team that responds as far as looking at some of the tests and everything that is contained in the estimated date of discharge board, that team would vary.
Yes.
And would you understand that from what you see on the discharge board?
I definitely think so. I think at the hospital, for stroke patients and for most patients, for all patients, you really have to look at a multidisciplinary approach. That's really the gold standard, where the whole world is going. Each patient is a whole person. You might be here with a specific complaint, a heart attack or a stroke, but there's a social component to it. What are your living circumstances at home? How do you cope with the aftermath of your illness and the long-lasting effects it might have on you? As persons in the hospital, they might need therapy, whether that be occupational therapy, speech therapy, physical therapy. The pharmacist is also involved in the care. So there are lots of moving parts as we care for a patient, and it's really important that everybody's involved and involved as early as possible. And these are things that you will see on the board. We want to know if you have to get a lab test done, what is the date it's supposed to happen, and when does it actually happen? Emphasis there on dates, not specifics of a test. If we want you to see the speech therapist or the occupational therapist, we want to know the dates that you were referred and then the dates that they actually came to see you. And then finally, before you go home, a really critical part of that would be your discharge medication, right? When you go home from the hospital, we want to make sure you have all of the medication that's necessary to keep you well at home and continue you on this upward trajectory of getting better and getting better. The other thing that's important to that is a discharge summary. So this is really a summary of everything that happened while you were in the hospital, instructions for what's to happen once you're discharged. So when do you come back to clinic? When do you follow up with your doctor? How do you take your medications? This is one of the most vital pieces of information that you will get when you're discharged from the hospital. And the board really has on the end of it a checklist to ensure that the medications have been ordered. If Granny is supposed to go home on Friday, the aim is to order the medications before Friday so that when Granny is ready to go home on Friday, she can go home. Same thing with a discharge summary. The aim is to prepare it before so that really it's just going to be a situation on Friday where the relatives can come and pick up Granny. The other thing in terms of involving the relatives, if for instance Granny had a stroke, we need a ramp at home. We need to have railings installed in the house so that she can bathe safely. So the relatives will know this is the date we're working towards and they have to get all of these things finished by then. If the relative shift work, for instance, they know that I have to be off on that day to receive Granny. If I have to organize a nurse or home care for Granny, I have to organize that before that date. So really it's supposed to be, once again, a central date that everybody can work towards. And the really important thing is that if we make the discharge process more efficient, the idea is that overall we can decrease the patient's amount of time they spend in the hospital and decrease the length of stay in the hospital, which is really important, for an efficient running facility.
Yes. And just to add to what Dr. Clarke was saying, she spoke about your take-home medication. We would have received a lot of complaints where patients were delayed for their discharges because they were awaiting the take-home medication. Now with our boards, we're able to see when the medication goes down to ensure that we're getting them back up for the date of discharge. And that is done 24 hours. It isn't before. Sometimes it will happen the same day. Now it happens 24 hours in advance so that when the discharge is ready, they have their medication to go home. So we thought that was a great improvement from that aspect. She also spoke about your discharge summary. This is new. I hope I don't take it out of the box. But what we are trying to do, one of our quality initiative, we are trying to launch a discharge summary information sheet. So all the details that you need for discharge will be on that sheet. Because most persons after discharge, they want to know, what do I do next? How do I get appointments? How do I get medication? Do I come back to the hospital? Do I go to another place to get my medication? And all of that information will be on your discharge information sheet that we're planning to launch soon.
Yeah, so it will be there at their fingertips, so to speak, but mainly at the staff's fingertips, because the doctors, the medical teams are the ones who are supposed to fill out those categories with the details about their patient, who they're caring for, and be able to say, well, this more than likely will be the date that they'll be discharged. Speaking, you spoke about medication there, Dr. Clarke. We got a WhatsApp coming in. Good morning. The pharma delivery is great. Thank you for that. However, sometimes you can't get through. And I always tell people, when you call that 536-4804, that is the pharmacy hotline, and it rings and you don't get an answer, it normally would put you to voicemail. So you leave a message, and the team there, Trudy is doing a wonderful work, Trudy Griffith, they're in the medication delivery service, and Michael as well. They will definitely get back to you and respond to your call for medication. So remember that number, 536-4804. And in the instant that you don't remember it, you can always go to our website, qehconnect.com. qehconnect.com. All right, so through this estimated date of discharge project, we have been able to, in the pilot phase, see some level of improvement. Can you describe the improvement? Can you describe what you saw in terms of using the boards and making it a whole lot better for staff and patients?
So in terms of the staff, so some of the staff have noted that they think that the boards could be extremely helpful to them in terms of knowing the important information about the patient beforehand and before it comes down to the end of that patient's stay. So I think that that's really been great. We have done some measurements over time to look at the average length of stay in the hospital, and we have seen a decrease in the average length of stay throughout the entire hospital during the first phase of the pilot, and an even larger decrease in the pilot wards. It's always important to note that just because two things happen at the same time, it might not be the cause, but it's something that we're going to watch and continue to monitor. I think that's really important.
Okay, we got some callers on the line. Good morning and welcome to the Pulse Radio Show, a production of the Queen Elizabeth Hospital. We're talking about the estimated date of discharge today, but how can we help?
Good morning, Shane.
Good morning, how are you doing?
Man, I just cooling it. I you, sir.
I didn't hear you. And you were asking how I'm doing?
Yes, sir, yes, sir.
I am exhausted. I am so tired. But I'm fighting. He's got to fight.
Yeah.
He's got to fight.
Okay, I want to ask you, doctor, something.
Go ahead.
I hope you're not restricted to...
No. Sure. Listen, we open this floor so you can ask any question. We are talking about the estimated date of discharge, helping to improve processes as far as our patients going through our hospital, making sure they're well taken care of, but making sure that they can get back home in a time that we believe is best case, I would say. Right, Dr. Clarke?
Definitely.
Yeah.
Okay, so, but you can ask any question. Go ahead.
I want to ask, you, doctor, what is the estimated date for discharge of a person with aneurysm?
Okay, so that's a good question, but it's very important that each case is looked at by the doctors individually. So there might be an estimated date. We might say, for instance, the evidence and what happens worldwide, it might be one thing, but when that patient comes in, depending what state they're in, if they have, diabetes or high blood pressure, if they weren't taking their medication, the effects of the aneurysm, all of that is going to affect what that estimated date of discharge. So your question really is a good question, because it highlights, that just looking at the diagnosis alone is not enough. And that's where the experience of our highly trained staff comes in, that they know what is the norm, what is supposed to be, but then they look at the entire patient as a whole, and they determine based on that they might add on a couple days or subtract a couple days. So we wouldn't be able to say that. It depends on what's going on with that specific patient.
Okay. You see, I have been listening to you, and I'm glad that the hospital is improving, and you have a board and this thing and that. I just want things to be good. I'm not criticizing, but I'm glad, because my mother was presented herself in 2002.
Right.
2002. Sorry, like 22. Sorry, Dr. Clarke, or whoever the person is. That's just
no problem. You got it right.
Yeah, I was about to say you have it right.
Yeah, 2022. And she was discharged within a week. And we got medication for her. But we kind of with aneurysm, we know that she was not in the... And she had dementia too.
Right.
So giving her medication was sort of an impossibility to us. We had to give her in drink. And she still died within another week. So I am glad that things are improving since then, and I'm glad at your motivations. I was listening to you all very carefully.
We appreciate that.
Yeah, and I'm saying that I appreciate your motivations and your goodwill towards your patients. And I want a bigger. I always big up this doctor all the time. You have a Dr. Rowe in your mix.
Yes, there is a Dr. Rowe in A&E.
Yes. I myself was sick one time, and Dr. Rowe dealt with me carefully. Myself, I don't mean no. I'm talking about my mother. Dr. Rowe, I will never forget Dr. Rowe. He's a very, 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 very good doctor. So continue with your motivations and your goodwill. And Shane, I know the doctors will help us.
Yeah, for sure. We thank you for calling and asking the question.
And thank you for sharing.
Indeed.
Yes,
Definitely.
Thank you for sharing. Have a wonderful day, my friend, and maybe continue to give you the information you need about our hospital. So we have another caller on the line. Good morning, morning caller. Welcome to the Pulse Radio Show. How can we help?
Good morning, Shane.
Hi, morning.
I just hopped through the door and heard the program on. I know it's beyond on Monday, but I was out doing a few things. But coming across in your preamble about getting discharged with a stroke patient, where the stroke patient has to be discharged, will be discharged, but yet the therapy, the ones with the ramp and the bathroom facilities for that patient will take some time, because I believe that when that person who does not have that facility before stroke and now has to have that in place, based on where the family structure is, they may have to rely on additional resources to get that facility in.
I think I see where you're going.
To see where that patient can be.
Yeah, so you're saying that in some cases the family may not be ready to handle their relative when they come back into the home.
Yes. And then you are left then with, what do I do? But yet, you can discharge her, but where can she go until we get that until you get those two facilities, bathroom and ramp, for the rehabilitation.
Well, it's a good example that you're giving, Colin. I'll let Dr. Clarke speak to that.
So, as you said, it's a great question. When persons come into the hospital and we discharge them, we want them to thrive when they go home.
Yeah,
and that's,
I really understand that, because I've seen recently a person who had a stroke with a backup and they're still mobile now, but with restriction, but yet they're doing well so far.
Right, definitely. And that's why before the patients go home, especially stroke patients, the appropriate assessments are done. Sometimes even the therapist often visit the patient's home to make sure it's ready and give the recommendations based on their expertise for what that patient will need, and if necessary can guide them in what's the best way to go about it. But we never aim to send home patients unless the home is appropriate to receive them and the family is willing to receive them. The other thing as well is that's why it's so important that you keep the lines of communication open between the patient and the relative and the healthcare workers that are involved in that care team, because you always want to send home the patient in the most safe way possible. So when you have concerns, you voice them with your care team, and hopefully the estimated date of discharge board will let you see, the patient is getting therapy, so there's a therapist on board. The patient might go home by this date, so it will give you time to prepare. The other thing I want to really encourage, the public to do and the patients to do is that when you see your estimated date of discharge board by the bedside, interact with it. Ask questions. Ask the staff questions about it. It's there to be helpful and to really, make sure that we're able to communicate and we can share information freely. So I think you really need to ask questions when you see it. Don't be afraid to ask the staff questions about it.
And also, as Dr. Clarke said, that is why this pilot that we're running is so important. That at the date when you're admitted, your estimated date of discharge. So if a patient has a stroke, there are certain things that are needed. And during that journey while in hospital, and you have issues that you're mentioning, we want you to let us know so that we can have our social services department engaged so that they can assist you in that area. They can come and give you your home assessments, and from there, connect you to the various agencies that will help you to prepare your home if you're unable to do it on your own. So we want to connect with you. We want the public to know that we're here to help you, and we want to engage you where that is concerned. We want, when you leave the QEH, that you're comfortable as much as possible.
Definitely, and it's important to note that, for instance, the social services arranging certain things for the relative once they go home, those things take time. So to wait to the end of the process, the day before the person's going home, to expect something to be done, that might be a bit unreasonable, and that's why we want to start the process as early as possible.
Yes, and on the boards, and Dr. Clarke would reiterate this again, there is a section which speaks to the meeting with family members, right, Dr. Clarke?
That's something that we added. That was actually based on the request of family and patients. That if you wanted to request a meeting, you would let the nurse know, and she would take that field. And the next time the doctors come about, they would know, for instance, that this family is requesting the meeting. Okay?
Yeah, thanks. I believe you can. I've been very interesting, because what had bothered me is how can you send a person who just had a stroke?
Right. So that would not happen.
And without facilities to accommodate, and that was my bother. But full explanation, I'm glad you granted it, and at least you can bring the show again, because that's one of those a very sensitive area in healthcare as far as I'm concerned. I spent some time in hospital already. That hospital in 1995, and I had excellent care both times I went, in 95 and 72. So I won't call some names now, because most of them have not there now, but I had excellent care at that time and those times.
Indeed. Well, that's good to hear. And we are happy that you can share that experience here with us on the Pulse Radio Show. And we want you to continue to support us here.
Yes, I support. I'm one of those persons who, because sometimes I have family relatives or families who have to go there to be there and have to be in and out
right
during the casualty, and information not shared, and because of the
so you can believe that we will be bridging that gap, that information gap, as we make sure that those relatives and the patient know when those meetings are being held, so that you can get the information that you need to help not only with the estimated date of discharge, but what happens thereafter in terms of the preparation. You can get that advice from us as well. So we'll talk about that a bit more when we come back from this commercial break.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Radio show, the last 15 minutes or so that we have with you, we'll continue to go through the rounds of the estimated date of discharge board, a new initiative to help improve patient flow onto the wards and through our hospital. Now, I know that relatives on that date, estimated date of discharge board, there's a section which speaks to meeting with relatives.
Yes.
Where they will get all of the information they need about their loved one who is in hospital. Yes, the estimated date of discharge. But a lot of them, or I should say in some cases, I've heard about the experiences which end up in what we call, or what is termed, elderly for care, where some relatives are unsure or uncertain about if they can indeed care for their relative when they return home. There are some other cases which, have a negative spin to it, where we put abandonment in quotation marks, but that is real. But the term used is elderly for care. So then they remain in our care, they take up their beds, but when they are fit for discharge. So what the boards will also do, I believe, is help us to communicate in a better way with the family so they can better prepare, so that we can reduce the incidence of EFCs at our hospital. Your thoughts, Dr. Clarke?
I think sometimes when there's not a lot of information about a topic, it can be scary. So for instance, if your relative, for instance, we can talk about strokes again, has a stroke, and you've never interacted with somebody with a stroke before, you don't know much about it. Obviously, the relative, depending on the severity of the stroke, they can have certain deficits or they can have a disability after. So I think that giving the patient and the relative, as much information as possible can help to alleviate or decrease some of that fear that might be surrounded with it. And that's why we want to involve everybody in the care. So we want them to sit and have a talk with the therapist. What are going to be the challenges that this patient might face when they go home? What are going to be their needs, and what's my role in that? And the hope is that with sharing information, we decrease some of the fear, and relatives are willing to take on the challenge and realize that it is something that can be done, all right, safely. But the aim is to have guidance from the experts on what's life going to look like when my relative comes home.
I'll let you add to that, Tricia, after this caller. A good morning, caller. Welcome to the Pulse Radio Show. We are here to help. How can we do that for you?
Hello, good morning.
Hi, good morning. How can we help?
I am calling with a problem I have.
Okay.
I am a patient of the hematology clinic.
Mm-hmm.
I went to the clinic in August. I didn't see anybody. When they had the meeting discussing the problems, I went to the meeting and everything.
Mm-hmm.
Up to now, nobody has called to give me a appointment, because I understand I got somebody working in that place.
Yes, The
But I
department.
didn't get no call to get no fresh appointment or nothing, so, and I'm just here in limbo.
The department is fully staffed. We always encourage persons to reach out as well. If you didn't get a call, there is a number that you can call to find out what needs to be the next step for you. But I'm happy to tell you that the staff is there. We have our consultant and
but
3 other
that's all I
doctors.
get through.
No, listen, when you call 536-4800, and we have our former acting patient relations manager here, and she can go through the process with you as well, because we want to make this as easy for you as possible. Before we even get to that process, before we wrap up this conversation, and when we do, I want you to leave your name with the producer so that we can reach out to you after this conversation.
Okay.
But here's the other option for you. You can call 536-4800, the number for our patient advice and liaison service, and the medical practitioner there would be able to assist you and guide you into getting that next appointment in the hematology clinic. I can tell you at that meeting, if you remember, Dr. Gill, who is the acting director of medical services, he would have given patients the option to come to him there and then, and he would have spearheaded that next course of treatment for all of those who came to him. He personally saw everyone who came down to him on that day. So that was then. We fast forward to now, where we have a fully staffed hematology clinic. Some people like yourself, unfortunately, and we do apologize for that, you falling through that crack and not getting the care that you need. So we want you to know you have the option. We will definitely reach out to you once you leave your details with our producer off air, because your health information needs to remain private. We need to keep that as private as possible. We don't want to share that on air. But what we want from you is that information. You give that to the producer, and then you also have the other option to call 536-4800. Tricia, you want to add anything to that?
Sure. I've heard this same situation from other callers at our PALS desk, and I'm asking the public, if you know that you have missed your hematology clinic appointment and you've not received a call, we're asking you to call our help desk at 536-4800 so we can get your name and get you back into the system. Because we want you to call, we want to ensure that your clinical care continues, so we're asking you to call us. We do not want anyone to be missed.
Yes, but for you, you can leave your name here with us. Leave your name with Andre. He will take your details and share it with us, and we will definitely reach out to you after the show.
Okay, thank you.
You're very welcome. Thanks for sharing. And this is what we want. We want people to call us. If you think that you're not getting the response you need, we are here to help, and that is what we want to do. Bridge that gap between the patients and the hospital to help you better understand how to navigate the system. That is what we were dealing with last week when Dr. Christine Greenidge, our Chief Operations Officer, was here, helping you to navigate the system. And one good starting point, a standard starting point with helping you to navigate the hospital system, is the patient advice and liaison service. We also tell you to call our PBX. You can also call 436-6450 and be directed to any department in our system. But for specific needs like that, where you need some direction as far as your care is concerned, definitely don't hesitate. Call the patient advice and liaison service at 536-4800. Before we went to the call, viewers, Dr. Clarke, she was mentioning about the importance of that conversation and the results that it will yield in terms of helping families better ready themselves to deal with that patient coming back home.
Yes. Oftentimes at our PALS desk and also from our clinical risk management unit, we would have received calls from relatives feeling very concerned that their family is being discharged and they're not ready for the family to come home for whatever reason. Sometimes the patient might have an amputation, and they're afraid of how do I take care of her now or him now that they have an amputation. So sometimes fear is the reason why patients are left in hospital, but we don't want you to be afraid. We want you to know that we're here to help you through the process. You also want to understand that home care sometimes is better care. Once we have finished our clinical treatment within hospital, patients thrive better in their homes and in their natural environments. So we need for the patient to leave our environment that once we have finished our care and move into their homes where they're more comfortable, and patients normally thrive better, they get into their own atmosphere. So we want to get them back into that environment. So that is important as well.
Yeah, because that is also, it would assist in terms of their mental health. They're in a space they're more familiar with, more accustomed to, so they may tend to recover better.
Yes.
Also, I think that they can speak to as part of this, the estimated date of discharge and the connection between families and hospital. We have our social workers as well that can speak to helping and direct some of the families for the care that their loved one would need after their discharge.
Definitely. And we have a great social work department at the hospital, and they're responsible for filling any gaps in the care that might be there, and helping guide the patient and the relatives to get the best care once they go home, coordinating any services, referring to all of the appropriate social services that are available in Barbados. That's really a great role that they serve. Placing persons in the hospital, so they do a wide range of things. Really a great department.
Yeah, and also our nurses in preparation for discharge, our nurses do a lot of teaching you how to take care of your wounds and stuff like that. And we want you to actually get that kind of teaching in preparation for your time home. And we're reaching out to you again. If you have concerns, you need to talk to us. Let us know what your concerns are. You're not supposed to be afraid to approach us and speak to us if you have a concern, because we want that once you've left the hospital that you're well aware of what your next steps are.
Okay. So, Dr. Clarke, where will the boards be found? What are there any areas which may not need the boards?
So we're doing a phased rollout, I would say. So it's going to be on most of the wards in the hospital, with an exception of a few. So definitely on the wards that see medical patients, medical admissions and surgical admissions, you will see the boards definitely. And the rest, we will continue. As I said, before we go with anything full steam ahead, we always have to try it out first, and see how we can make the best product to work for those other wards that might not be getting boards right now.
Maternity ward too?
So right now, women and children will not be getting the boards, but all medicine and surgery wards will be getting the boards.
No, I asked that because I started to think about Sharmina Curtin, our registered nurse who does that education on breastfeeding. She has a breastfeeding forum this evening for those expecting mothers or new mothers out there, and we got to tell you how you can connect with that. So we'll share that as we wrap up the show. So final thoughts from both of you. Estimated date of discharge. The video will be soon out. What should people look out for?
Well, they can look out and see the video. We're asking for all the feedback that you can give. While your relatives are here, we are also asking for feedback. We usually have surveys as we give out our handbook, our inpatient handbook, so you're free to use the QR codes at the back of the handbook and fill it out and let us hear from you. We want to hear from you.
And there's one other key point as far as the discharge boards are concerned. Remember, we're trying to keep individuals' health information confidential, and we do that even with a fully filled out board.
Yes.
Any do's and don'ts?
So definitely. So we want you to, as I said earlier, engage with the board, ask questions about the board. But we one of the things that we are so passionate about is also protecting your relatives' privacy. That's why we really implore you to, there should be no photography of the board, so you're free to, look at the information and utilize the information, but we really want to protect your relatives, so we implore you that, photography of the board will be strictly prohibited. But I do think that the board really represents, we can tell that the hospital is really committed to improving communication with the public,
Definitely.
Engagement with the public,
Yep.
and continuous improvement. And that echoes, some of what I heard from the patients when I asked them what they thought about the board. They say, I see you're trying. One of them also mentioned as well, we all get sick, we all come here, and they really appreciate that we're trying to move in the right direction. So really look out for the boards. It's an estimated date of discharge board. It has all of the information which is important to getting the patient or your relatives or loved ones at home safely. All right, and we just we are excited to see you all interact with them and get further feedback from relatives and patients once they go on more wards in the hospital.
Yeah, we just got a question there from our WhatsApp about if individuals, I'm thinking family, because family should, and next of kin really, should be only person really getting an explanation about what's on the board, and they were wondering if they were able to write down information from the board.
So yes, you'll be able to write down the information, but photography, we really wouldn't want any photography of the board. But writing down, obviously, if you have an estimated date of discharge for your relative, you might walk away. Being in the hospital, seeing your relative in that state can make you, quite anxious. And sometimes we know people talk to us, or the doctor talks to us, and we walk away after that and forget everything that was said. So I do, I'm a big supporter of taking notes, definitely. But we want to protect the patient's privacy and relatives' privacy. And as usual, information that's critical to the patient's care is only discussed with the next of kin.
Correct.
Or whoever the patient has determined, they want that discussion to be had with.
Yeah, it's something that we need to reiterate. We spoke about that too last week, that the next of kin is the one that can have access to their relatives' information. They can share it with the family, but they are the primary person they're the person in the position to get the information, especially from that estimated date of discharge board. Ladies, thank you so much for coming and sharing all about this new initiative, expected to roll out right across our hospital very soon. For those patients, you can look out, and we are really driving this process to improve the level of care that we deliver to you, our valued patients, and really to all of Barbados who use our hospital. Thank you very much, Service Improvement Manager Dr. Ayja Clarke, and thank you very much, Quality Lead, Acting Quality Manager Tricia Ward. And I'm Shane Seeley, and that's all the time we have for this edition of the Pulse Radio Show. Remember, you can get a repeat on this show later tonight here on Q100.7 FM, but also on our social media channels, mainly our website. You go there and you'll see all of the podcasts under the tab called The Pulse. That's what this is, the Pulse of the Queen Elizabeth Hospital. Thank you for listening, and until next time, have a wonderful week.
The QEH Pulse Radio Show brought to you with the compliments of MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.